Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our tumor board. And I'm going to ask our esteemed panelists if they wouldn't mind going ahead and introducing themselves. We'll start out with Dr. O'Shaughnessy.
Hi everyone. Joyce O'Shaughnessy. I'm in Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas, and I'm a breast medical oncologist. Very nice to be here with you today.
I am Dr. Frank Piccini, radiation oncologist with Genesis Care in Michigan.
Hi, I'm Norman Woolmark. I'm professor of surgery at the University of Pittsburgh. I'm chairman of the NSABP Foundation and co-principal PI of NRG Oncology.
I'm Maxine Jockelson, and I am a professor of radiology at Memorial Sloan Kettering Cancer Center, where I direct the imaging for the Breast and Imaging Center. I'm primarily a breast imager with a little sideshow of doing PET scanning as well.
34 years of age. She is 13 weeks pregnant with a new right node positive grade 3 invasive ductal carcinoma. This is ER and PR negative and HER2 positive. So given her current pregnancy at 13 weeks gestation, what would be the best sort of treatment and then also sequence of treatment for this particular patient? This is going to be the challenging situation that we're going to ask you all to tackle today. So this patient palpated a right breast mass in October of 2020. She did not seek workup until December, as at that time she had a difficult social situation. She was homeless and in the process of relocating to a different state, to Massachusetts. She has an excellent performance status. She has no other significant medical history. Menarche was at age 12. She's certainly premenopausal, G9, P6, no history of breastfeeding, no oral contraceptives or hormone replacement. She's a former smoker with a 9-pack year history, but is not currently smoking, no alcohol or drug use, and no family history of malignancy at all. As I mentioned, in October of 2020, she palpated the right breast mass. She subsequently was homeless, living in Florida. She relocated to Massachusetts in November. She achieved a stable housing environment in late November of 2020. And then in December of 2020, was noted to have this 3 by 2.2 centimeter mass in the right upper outer quadrant on mammogram and ultrasound. The biopsy, as I mentioned, showed a grade 3 invasive ductal carcinoma, ER and PR negative, HER2 positive. In January of 2021, she underwent a right axillary sonogram of a 1.3 by 0.7 centimeter lymph node that had a thickened cortex. The biopsy demonstrated metastatic cells in this one lymph node. In the workup, she was found to be 13 weeks pregnant as of March 3rd of 2021. So right kind of in the middle of the pandemic and everything else on top of everything that this particular woman's dealing with. She had a right chest x-ray and abdominal ultrasound, which was negative for any evidence of a metastatic disease. Of course, that was considered the appropriate metastatic workup given the pregnancy. She couldn't undergo traditional staging, for example. We have some imaging slides here. If Dr. Jockelson, you want to comment about these?
Sure. We have an MLO and craniocaudate view of her right breast. And you can see in the upper outer quadrant, there is what we would call a focal asymmetry because you can't see the mass discretely, but clearly it's abnormal. And I get the feeling that there is a biopsy marker in it on these films, although I can't blow them up to say for sure. She has dense breasts, but otherwise nothing else to add in terms of the mammographic finding.
Thank you so much. All right, so given her current pregnancy at 13 weeks gestation, and given the biology here that this is ER/PR negative and HER2 positive, the best order of treatment for this particular patient. So maybe Dr. Woolmark, we'll start with you. What are your thoughts about how you would approach this patient?
Well, the classic default approach was always interrupt the tumor and not the pregnancy. In this situation, however, given the fact that she's HER2 positive and that the use of Herceptin during pregnancy would create issues that are unwanted, such as oligohydramnios and pulmonary hypoplasia and other lethal abnormalities in the fetus, that certainly is not an option to give her Herceptin while she's pregnant. Also, given the fact that she is gravida 9, para 6, and this is an unplanned pregnancy, I think one has to have a discussion with the patient, because I think that the most effective course here would be to terminate the pregnancy and to proceed with HER2-directed neoadjuvant therapy. And from my perspective, this would be the preferred approach. If that's not feasible, I think we have to introduce innovative therapeutic sequences, such as chemotherapy, and then delay the Herceptin, and we certainly know that's certainly a lot less effective than giving it concurrently. So to sum up, I would prefer, from a therapeutic standpoint, to initiate therapy as quickly as possible, which would mean terminating the pregnancy to start neoadjuvant HER2-targeted therapy.
Perfect. Thank you so much for your thoughts. Would there be a scenario in which, let's say that the patient wasn't amenable to that idea and wanted to continue with the pregnancy? How would you feel about a surgery first approach? Is that something that you would consider?
Yes, I think you have to tailor the treatment based on the reality of the scenario. If the patient is unwilling to terminate the pregnancy, I think one option would be to perform operative intervention, and I think that's a reasonable approach. I think utilizing chemotherapy would be reasonable as well, but I think the sooner one starts targeted therapy for a HER2-positive tumor, the better. And I think operative or doing a mastectomy and axillary node dissection, if the patient wants to continue with the pregnancy, would be an option. It would not hasten the initiation of HER2-targeted therapy. We're still left with that. So an alternative would be to initiate non-HER2-targeted therapy while she is pregnant, if she does not want to terminate the pregnancy.
Thank you so much. Dr. O'Shaughnessy, could you comment for us I think we kind of have to approach it in both scenarios. One is that she wants to continue the pregnancy, in which case we might choose a surgery first approach. The other is that if she doesn't want to continue the pregnancy. Can you comment about kind of both of those scenarios for us?
Yeah, and I agree with Dr. Wallmark. I would really sit down and talk to her about the fact that the treatment we would have, the standard of care, would probably for most people be a docetaxel, carboplatin, trastuzumab, and pertuzumab preoperative strategy. And with an ER/PR negative breast cancer, the pathologic complete response rate is around 80%. And so the outcome is so good with our current therapy. And we just really don't know exactly how treatment performs. And particularly if we do know from the affinity trial that if you look at an AC followed by a taxane, trastuzumab, pertuzumab versus a TCHP, they weren't compared head to head, but the outcome looks very similar between the two. And also we've seen in the BCRG 006 trial that the TCH was, approximately equivalent to an ACTH. So I think we're okay starting with an AC, but the thing is, we don't have good data about whether these agents perform just as well in the milieu of pregnancy as they do in the non-pregnant individual. We simply don't have the data. So I would really have to tell her about that. And, since she has probably a lot of responsibility with a large family, it's something she may want to consider is termination. And certainly from the point of view of her overall survivorship, I'd be most comfortable with that. And then I would recommend a TCHP approach to her. If she opts to continue the pregnancy, then I think I would go with an AC regimen every 3 weeks for 4 cycles to basically spread out the amount of time that we're going to be giving her chemotherapy and get her. Now, I would generally speaking go with surgery first, even though this is something we always give preoperative therapy, again, for the simple reason that it's difficult to even monitor the effectiveness sometimes of the therapy in the pregnant breast. For example, we're limited on, the amount of imaging we can do. We can do ultrasonography, but sometimes it's difficult to tell exactly. So plus, I just don't know for sure what the effectiveness is of the systemic therapy, in the pregnancy. So generally, I'd be looking to go to surgery first. And so that would get her a little bit further down the road by the time she healed up from surgery. So we give her 12 weeks of AC, but then she still may have quite a bit of time before it's safe for her to deliver. So I was refreshing my memory on where we stand with paclitaxel, Carboplatin, and also trastuzumab in the pregnant woman. And the FDA still has the label that the trastuzumab, as Dr. Walmark said, is contraindicated, in a pregnant individual. However, I was doing a literature search, and it turns out that there's a kind of a growing number of case reports. There's a paper that had 7 women who got trastuzumab either by accident because they were getting it first trimester, they didn't know they were pregnant, or they had metastatic disease and opted to keep their pregnancy. And 6 of the 7 children did well. One had the oligohydramnios, the pulmonary hyperplasia, and the baby died. But the other 6 did very, very well, including patients who were exposed to trastuzumab in the first trimester. There were several of them. So, particularly as we get into the 3rd trimester, if we needed to give some, and there's growing data for the safety of a paclitaxel Carboplatin combination. So if we needed to give some paclitaxel trastuzumab late in the course, watching things very carefully, based on the available data, and so discussion with the patient, et cetera, that's something I would be probably okay with doing. But because she's high risk with node positive disease and this biology. So I'd be looking to try to balance that, of course, but I would kind of be erring on the side of trying to keep the therapy going for her until she can get to delivery.
Perfect. Okay. And maybe Dr. Vicini, would you mind commenting for us, given the node positivity here? Is this a patient, given that she's so young, would you recommend post-mastectomy radiation therapy for her?
Yeah, the most likely scenario is that she will require post-mastectomy radiation therapy. And unfortunately, I know we didn't talk about it, pregnancy is still a contraindications to radiation. It's really the internal scatter, and as much as we've advanced our techniques, there's no way to stop the scatter to the growing fetus. So, but yeah, most likely she's going to need radiation therapy, and there will be scatter to the fetus if we delivered it before she delivered.
Okay. Thank you all so much. Anyone have any other comments? This is a really challenging situation.
It is. It's a very challenging situation. Frank, if we were to treat her with neoadjuvant dual targeted HER2 therapy, and she developed a PCR in the breast and nose, would you still want to give her regional radiotherapy?
Well, I don't know if pregnancy was allowed on B51, NSABP51. I'm sure it was a contraindication.
Let's take the pregnancy off the table.
Yeah. Well, we'll see what B51 shows, but I mean, the bottom line is, still today, we actually just looked at this across the country, practice patterns, and even with the pathologic complete response, most institutions are offering radiation therapy, but it's something that it will change, hopefully, in the future. There are some data that suggests that she perhaps could do fine without it.
Thank you so much for that. So kind of to summarize, we would approach this patient with a careful discussion about whether or not she wanted to continue with the pregnancy, understanding that her prognosis and certainly her overall survival is going to be best if there's termination of pregnancy to allow for optimal therapy, including neoadjuvant chemotherapy, followed by surgery, followed by post-mastectomy radiation as a most likely scenario for termination of the pregnancy. If the patient desires to keep the pregnancy, the recommendation would be to proceed with neoadjuvant chemotherapy with an adriamycin Cytoxan combination given every 3 weeks to prolong the duration of treatment. And then, with careful consultation with maternal-fetal medicine, consider, administration of Carboplatin and paclitaxel plus or minus the trastuzumab to get us to the point of safe delivery of the baby, and then continue with the remainder of the standard of care treatment after delivery.